Hello and welcome to today's Rsna webinar, Leveraging the Full Potential of AI, Radiologists and Data Scientists Working Together. I'm Charles Kahn, a radiologist on faculty at the University of Pennsylvania and editor of the journal Radiology Artificial Intelligence. It's my great pleasure to moderate this session, which is offered by RSNA in collaboration with Mikai, the Medical Image Computing and Computer-Assisted Intervention Society. You'll learn more about Mikai from our speakers who are distinguished members of that society. With us today are Marius Linguraru, Lena Meyerhein, and Ronald Summers. Before I formally introduce the speakers, there are a few things to let you know. This webinar is one of the many ways that RSNA is reaching the radiology community to provide education and resources particularly in relation to AI in radiology. And today's webinar will be recorded and available on RSNA's YouTube channel within the next several days. Here is the RSNA disclaimer statement. Today's program is a Zoom webinar, which means that audience members can listen and view only. You cannot unmute or start your camera. We do encourage you, though, to use the Q&A icon to submit your questions during the webinar. You also can upvote someone else's question by clicking the thumbs up icon, and doing so will help us select questions that are of the greatest interest to the group. So now I would like to introduce our speakers. Marius George Linguraru is principal investigator in the Sheikh Zayed Institute for Pediatric Surgical Innovation at Children's National Hospital, and is professor of radiology and pediatrics at George Washington University. He co-founded Pediametrics, a company focused on infant well-being, was previously with the NIH, completed his doctorate at University of Oxford, and held a fellowship at Harvard University. He's a member of the board of directors of the Mikai Society. Dr. Lainer Meyerhein received a diploma and a PhD degree with distinction from Karlsruhe Institute of Technology and conducted her postdoctoral work at the German Cancer Research Center and the Hamlin Center for Robotic Surgery at Imperial College London. And during her time as a junior group leader at the Cancer Research Center, she finished her habilitation at the University of Heidelberg. As a division head, she is working in the field of biomedical image analysis with a specific focus on surgical data science, computational biophotonics, and validation of machine learning algorithms. She's a fellow of the Mikai Society and of the European Laboratory for Learning and Intelligence Systems, and has been distinguished with several science awards, including the 2013 Heinz Meyer-Leibniz Award from the German Research Foundation. Dr. Ronald Summers is a tenured senior investigator at the NIH Clinical Center. His research interests include deep learning, large radiology databases, and abdominal imaging. He has published more than 500 journal articles and conference proceedings papers, and is a co-inventor on 14 patents, a distinguished panel, all of them. So welcome, Drs. Linguraru, Meyerhein, and Summers. So Dr. Linguraru will begin with his presentation, What is a Mikai Scientist?
Thank you for RSNA for this opportunity to be here in the webinar. I would like to tell you shortly what is a Mikai scientist, such as myself. And for that, I will start by introducing and saying a few words about the Mikai Society. As you've already heard, this is the Medical Image Computing and Computer-Assisted Intervention Society. It's a non-profit scientific organization whose goal is to advance the areas that are represented by its title. Just like RSNA, Mikai is a global society and it has members from all corners of the world. Also has members from multidisciplinary backgrounds, such as scientists, physicians, engineers, and educators. And because of a strong educational component that we have, about half of the members of the society are students. The Mikai Society started around its flagship annual conference, which ignited in 1998 and attracts about 2,400 attendees every year. Just like the society, the conference is global as well. And unlike RSNA, our meetings are held at different locations every year. So for instance, in 2020, although it was virtual, we were supposed to be in Peru. This year, the meeting is going to be in France, next year in Singapore, the year after in Canada, and in 2024 in Morocco. So we're really trying to work with people from all corners of the world who are interested in the area of Mikai. At the conference, we have also satellite events such as workshops, tutorials, and challenges. And you will hear about challenges, these important activities that are happening at Mikai and RSNA as well, and some of the challenges, opportunities, and pitfalls with them and organizing them. The Mikai Society is very focused on advances in methodology and applications, and AI is under this umbrella. But also the society wants to promote technical and clinical validation and development of evaluation standards. And for that, we work with other societies and industry, including RSNA. And why we're here together is because RSNA and Mikai have a very natural relationship. And members of the Mikai Society attend RSNA regularly. You know, you see us in the exhibition booths, at some of the scientific posters, because, and this is now in the words of RSNA, we're all interested in advancing quantitative imaging biomarkers and developing radiologic technologies, particularly in the area of artificial intelligence. I'm highlighting these these keywords because I will speak more about them in my presentation. But also key to both RSNA and Mikai is to have collaborations between clinicians and scientists to facilitate the clinical success of quantitative imaging and machine learning. And we started to formalize more our relationship between the two societies with the panel that we hosted at Mikai 2020. I moderated that panel, but the speakers were really distinguished members of the RSNA Society. And we had 587 live attendees and many others who watched the recording online. And with that, I'll switch to really what is a Mikai scientist. And you'll have to accept it with a little bit of bias. It's mostly about what kind of Mikai scientist I am. And the area of interest in my work is precision imaging, which is really a combination of quantitative imaging and artificial intelligence. And I'd like to very briefly take you to some examples of work. And I will start by saying, what is quantitative imaging? This is one of the buzzwords that I think everybody here knows well. But I thought, since I'm speaking to many radiologists, I will not show an example from radiology. But you may be wondering, why are we looking at images of the Last Supper and paintings of that? Well, some colleagues who published in the International Journal of Obesity had the same question. And they were looking at the relative size of the main dish in these paintings. And you can see from this graph, the size of the main dish has increased over time. So here we have, briefly, quantitative imaging. We have healthcare as well. Artificial intelligence, and I mainly refer to machine learning and deep learning. That's another buzzword that I think we hear very often around in the society, at work. It's everywhere. It's omnipresent. And what I would like to explain is how I see this as a former computer scientist who still thinks sometimes is a computer scientist. So when I started programming and creating medical imaging applications, I was giving some data, like I'm abstractly showing in this image, and then I was writing some software code, a computer program, for which I was using a computational environment to get an outcome. And this outcome could be to have something timely, a pattern of infection in the lungs of a patient with COVID-19. So what has changed and dramatically changed, if you see the little animation, now if we flip, if we give the data to the machine and we indicate what kind of outcome we want, then the machine writes its own code. And this is what really machine learning means. The computer becomes much more independent in its thinking. So we see machine learning, artificial intelligence all around us in the society, from self-driving cars, which is something I can't wait to be omnipresent, to facial analysis, facial recognition. We see this in airports, we see this in now passports. It's again, everywhere. It's on social media. In the time of pandemic, looking at for PPEs and recognizing the correct use of PPEs. Or in the general healthcare field, here is a study that was looking at publications and impact on the healthcare by artificial intelligence over time. And you see at the top of this graph, diagnostic imaging. So radiology has really been a pioneering field in adapting and using AI in healthcare, although obviously this AI is impacting many other areas of healthcare. Or as this cover on The Economist showed, this is where some of our work was featured as well, there's really nowhere to hide. This example is, and everyone who's interested can look at how artificial intelligence impacts facial recognition, but really we know that artificial intelligence has a much larger impact on a society. So one example I wanted to show you, again, I was showing you faces and facial recognition. How do we do this in healthcare? Here are some images of newborn babies. It's a project between Children's National and the Ministry of Health and Prevention in the UAE that we started, and we have many other partners from around the world. We're looking at faces of newborns, and we want to understand if they are at risk to have an inborn condition, which about 80% of this condition have a genetic cause. So we're trying to understand genotype, but we also have to understand phenotype, because children look different based on their origin. And therefore, diversity is really important in analyzing a face, looking at a face of a newborn. This is something that the human brain and human eye can perceive well, but it requires access to a lot of data, a lot of diversity. So a machine has a potential to do it well, or even better. So what we propose is to do deep phenotyping on the faces of these babies. Basically, we compute lots of things on their faces, which is the QI, quantitative imaging part. But then we have this diverse, large data, hard to interpret. Then we use AI, the machine intelligence factor, to identify a newborn to be at risk or not to have a genetic condition. More in the realm of radiology, and also inspired by the global pandemic, we put together a large consortium, which was led by the industry leader NVIDIA and the Massachusetts and Brigham hospitals at the Harvard Medical School, to create a predictive model of oxygen requirement in SARS-CoV-2. So for that, we collected chest X-rays at the first presentation of a patient with clinical parameters, such as blood tests, data from the EMR, symptoms, everything can be put in there. Again, diverse data that gets mixed together. And then we wanted to triage patients whether they need, in the next 24 to 72 hours, supplemental oxygen, and how much supplemental oxygen, what type. And for this, we had 20 sites from 8 countries and 16,000 subjects that we collected over a short period of time. And the tools that we used for this was this scientific paradigm called Federated Learning, in which you create a deep learning model that sits somewhere in the middle between the sites. And I'm, of course, speaking metaphorically here. But basically, you create a model, and you take the model to each one of the sites and run it locally, so to learn the parameters of the model, which you then bring together and join with the parameters from all sides. So bring the model to the data, not the data to the model. And why is this important? Because it alleviates difficulties with sharing data, it accelerates knowledge, and it also protects patient data. And one of the advantages of this approach is that, as we know, deep learning requires lots and lots of data to be good. And again, we'll hear more about this from my colleagues as well. So for every site, what we found out that if you use the data, the parameters of the data to federated learning, we obtain more than 16% performance improvement. So this is especially important for sites who have little data, where a local model is not going to be accurate. And this is shown in blue. But the global model is actually very accurate, as shown in green. And there was also a 38% increase in generalizability. And generalizability is, again, very important for AI in healthcare. Just briefly, I mentioned that we also organized a grand challenge at the end of last year for looking at lung CT lesion segmentations for COVID-19. And for this, we provided access to public resources, because that's really important, not just with new diseases, maybe that's even more critical, but with other diseases as well, to have common platforms with large data, common data, open data, so that participants from all around the world can create their own tools. And here we had CT scans, which were curated and annotated, and again, shared publicly, but we also provided a deep learning-based platform that others could use to build their own AI algorithms. In about a month, we had over 1,000 teams who registered to participate. They were from 29 countries on 6 continents. And I think this is a reflection that not just that COVID-19 is a global burden, but also that the scientific community wants to participate in helping and providing better healthcare for conditions that affect us all. So the conclusion of my talk is that quantitative imaging and artificial intelligence may often look like a black box, but they are not a magic box. So they are really computational platforms that we can learn to trust better, and we have to learn how to work with, and that could provide quite a lot of benefits for healthcare. And for this, I'd like to thank again Rsna and Mikai for this opportunity, my many colleagues from Children's National, NIH, NVIDIA, and the UAE who participated at this. Some of them are MDs, some are PhDs, some are both. But importantly, there were radiologists and data scientists who worked together on these projects. Thank you.
Thanks very much, Marius. That was a great presentation. I'd like to welcome next Dr. Lena Meyerhein to speak on AI validation and pitfalls. We have your slides.
Thank you very much, Marius. Also, this was basically you pointed at the promises of AI. Now I want to talk a little bit about the problems that we still face, because maybe you all have seen, you know, all these media reports of the algorithms beating radiologists, cardiologists, dermatologists, but you feel that all these promises haven't arrived in clinical practice. And my personal belief is that we don't validate algorithms properly, and this is one of the reasons for this phenomenon. Well, I actually specialized on AI during my studies, and I remember my professor, Professor Weibel, saying there's no data like more data. And yeah, that's what a data scientist thinks. You need as much data as you can get. But you have to be careful on how you generate this data. And I was quite impressed by this recent hot off the press paper, where you see how authors basically merge different sources of information to train and test their algorithms. Here, this was about COVID-19 detection or diagnosis. And I was shocked to learn that many authors actually merged data sets of adult COVID-19 patients with a data set of infants with pneumonia. Now, you can imagine what happens. Basically, an algorithm that is able to distinguish infants from adults will get 100% accuracy. And this is just one example of many possible confounders. There's much more. I recommend you also this paper on the topic. Here, for example, you see cables in the image, which of course is a confounder when we think about disease detection or diagnosis. Also, imaging protocols may play a role, as you know best. So really, we need to think very carefully on how we gather the data for training and then testing our methods. Now, let's assume we have a good data set. Then the next question we need to ask ourselves is, how do we assess the value of an algorithm? And I really like this piece of history here that happened in Vietnam, where there was a rat plague and people would get a monetary award for rat tails because, basically this was used as a proxy for killing the rats. But what happened in practice was that people just cut off the tails and let the rats alive such that they could reproduce. So the people could get even more tails and thus more money. And I think it's a good example of metric failure. So you don't actually measure what you want to measure. And this happens, from my point of view, a lot in radiological data science as well. So those of you who have worked with AI may have come across the Dsc, the Dissimilarity Coefficient. It's the most widely used metric actually in biomedical image analysis. And it's used mainly for segmentation. So imagine you have a reference, a contour blue from a radiologist. This could be a tumor, for example. You have the algorithm output in orange. Now, this metric basically takes the volume of the overlap and the volume of the individual contours and outputs a measure between 0 no overlap, and 1, perfect overlap. So this makes sense at first sight, but there's many pitfalls. So I want to give you just 2 examples. One is using a segmentation metric for detection. So I'm sure all of you will agree with me that if you have 3 lesions, for example, then this prediction, this algorithm 2, is much better reflecting what we clinically want, because it actually detects all the 3 regions, compared to the first one, which only detects 1 lesion better. But this is not reflected in the metric because it's not a detection metric. Now you could argue, well, okay, but then let's use the DSC per lesion, and this is also done a lot. But there's also pitfalls with this. So for example, if you have very small structures, like in the first row here, you see that a single pixel difference has a huge effect on the metric. I mean, 0.5 versus 0.8 on a scale 0 to 1 is a game changer, basically. And all of this becomes even more important if you think about all the uncertainties that occur in this whole process. For example, Leo Joskovic published this great paper, I think, where they show that there's a huge inter-rater variability when you actually segment different structures. I mean, look at these contour differences and then think of the effect of a single pixel. And also, what is probably less commonly known is also the data science perspective on it. So when you have a certain neural network architecture and you have certain data and you train your architecture, then you don't actually always get the same result. This is a misconception. There's non-deterministic effects, and these can also have an effect. And then again, this renders a single pixel difference really potentially irrelevant. So I just scratched the surface, but we're working on it. So we have a consortium between Mikai, MONAI, and also the Bias Consortium, where we want to come up with best practice recommendations for the community. We want to highlight all the pitfalls, but still, I think it's crucial that for a given clinical application that you have, you work together, the clinicians with the data science, to really make sure that the metrics reflect what is clinically relevant in the end. Now, let's assume we have a good metric or set of metrics, we have good data. Then we have to do the benchmarking. And this is typically done via challenges. So challenges are essentially international competitions where you compare algorithms on identical data sets. We do this just like the clinicians do clinical trials. We do in the machine learning community typically these international challenges. And a lot of attention is given to the winners. I mean, that's the new state of the art. Can be a lot of prize money involved, et cetera, et cetera. And at some point, we developed the hypothesis that there may be a discrepancy between the impact of challenges and the actual quality control. So we asked ourselves, is the winner really the best? And core contributors for this were actually the great team I'm working with as part of the Mikai board activities, but also a whole bunch of other institutes worldwide. So I'm just basically presenting this very shortly on their behalf. So what we found, just a summary, because we want to have time for discussion. First of all, we found that results are not reproducibility or even interpretable because there's a lot of information missing. So what we did here is we basically came up with something like a checklist that you should fill out when you report on a challenge. This was also accepted by the Equator Network as an official guideline now, and we use it also for challenge review. So when in the Mikai Society somebody wants to organize a challenge, then they have to fill out that whole checklist. It's quite long actually, justifying all the specific design choices, and then the review is based on this. It's like a paper review basically. And then secondly, we looked at, this is for most people always the most exciting bit, at the ranking stability. And I don't have time to go into this in detail, but I want to show you one example, I think, that clarifies what is happening. So here, and you can read all the comprehensive assessment based on actually more than 500 individual competitions in this Nature Communications paper that I'm citing here, but I just give you one example. This is a real world challenge that has happened multiple times, many citations, many participants. We have the real world data, and now we play around a little bit with how we rank participants. So the first obvious thing is the metric. We already talked about the DSC. You can also use the Hausdorff distance, or its 95% variant. You can play around with the way you aggregate. So do you first basically take each test case, computer rank for it, and then aggregate ranks? Or do you first aggregate all your metric values and then compute the rank? And you can play around with a aggregator. Do you, for example, take the mean or the median? I mean, these are just examples, but when you play around with these, you see that really the ranking can change radically. And the same holds true if you look at different observers that annotate the data or leaving out test data, for example. I mean, like I said, we analyzed quite a few challenges, and in one extreme case, we actually made the poorest performing algorithm the winner by removing one test case. So this is actually not only important in challenges, and this is I think my almost last slide now. So this is not only important in challenges, but also if you benchmark your own algorithm. So imagine you have developed an algorithm, let's call it algorithm 1. You see the box plots here of the performances, and I'm sure you would prefer this box plot here, the raw box plot. But when we just present ranking tables, then such differences do not become very apparent. We also work on this as part of the Mikai activities. And if you're interested, have a look at the open source toolkit that we just published, where such ranking and instabilities can be taken into account. Yeah, and last thing that I will not talk about is cheating. So we also identified a few ways how people can actually cheat in such competitions and tune the rankings. And we have proposed several means to overcome such issues. I know I made a long story very short. I was quite anecdotal, but what I really was trying to say is that the way we validate today, I think, is not fully adequate. And we really need to collaborate in a transdisciplinary manner. We need the expertise of the radiologists, of the clinicians in general, and of the data scientists together to come up with good validation strategies. Yeah, I think my team members especially, and also, of course, all the collaborators who contributed to this. Thank you for your attention.
Thank you so much, Lena. Excellent presentation. Our third presentation is by Dr. Ron Summers, who will present Radiologists and Data Scientists Working Together, a Radiologist Perspective. And Ron, we have your slides up.
Great, thanks very much, Dr. Kahn, and thank you to my distinguished colleagues on this panel. It's a great pleasure to speak to you today about radiologists and data scientists working together, a radiologist perspective. I'm Ron Summers at the NIH Clinical Center, and these are my disclosures. I thought I'd start with some personal background about why I started an artificial intelligence lab at NIH. I've long been fascinated with computer applications in radiology. And back when I was a radiology resident at the University of Michigan in Ann Arbor, I wrote a personal teaching file program that I presented at Rsna. I wrote that in Visual Basic. So I'm truly a dinosaur when it comes to computer programming. Another reason I started an AI lab was that as I've been practicing radiology, I and every other radiologist has had to deal with the deluge of images and information as the scanners became faster, produced high resolution images and more informative images. And I've also been very excited about using AI to perform scientific discovery. I thought I'd say a few words about who works in my AI lab, so you can get a sense of the diverse talents that are needed to make progress. In addition to radiologists such as myself and my colleague, Dr. Grace Lee, we have medical image processing scientists, including computer scientists, biomedical engineers, a physicist, postdoctoral fellows, and pre-medical students. What are the roles of the data scientists in my lab? Well, they design the studies, they collect, manage, and curate the data, which is sometimes referred to as data wrangling, which is a very time-consuming process. They design, train, and validate the AI, and sometimes the training process can be quite time-consuming. They perform the statistical analyses, write manuscripts, and mentor and select trainees. So in contrast, what is the radiologist's role? Well, radiologists in an AI lab typically lead the team. We can focus on the big picture to guide and approve project selection. And essentially, this is by ensuring clinical utility and generalizability and performing that exceptionally important clinical reality check. We also teach anatomy and pathology, review the data, and sometimes perform the critical annotations. I'd like to say a few words about project selection because I found it so critical that one chooses the right projects, because once that choice is made, one can spend hundreds, if not thousands of hours on a project. I believe, based on my experience, that projects that sometimes are considered simple can sometimes be very impactful. An example of that is shown on the left of an AI system that detects the muscle on an abdominal CT and can be used to assess the frailty of a patient. And numerous publications have shown that frailty is a risk factor in patients undergoing surgery or chemotherapy, and can also be used to predict survival and other morbidities. On the other hand, I think one needs a balance between simple and aspirational projects. And on the right, I show what I call an aspirational project, which is something we've dubbed universal lesion detection. This is an AI algorithm that can find lesions of any type on body CT scans. And this is an example from work that was led by Kahn and Joe Burns. This is the work from Joe Burns. This is from Kahn. This example shows an AI system, a universal lesion detector that can find a left adrenal lesion, can describe it properly, and then can make measurements of the lesion all fully automatically. Another topic that I mentioned earlier that I'd like to discuss in just a little bit more detail is the important role that radiologists have in conducting expert annotations. This is an example of the use of a public data set, in this case, the NIH Chest X-ray 8 data set that we released back a number of years ago. This data set was repurposed for an RSNA challenge in 2018. Here I'm talking about the data set to a group at the finale for this competition. And what happened there was that a group of 18 radiologists unrelated to my group relabeled 30,000 of the chest x-rays for the RSNA pneumonia detection challenge that was held that year. So these 18 radiologists performed a critical role in generating the reference standard that was then used by over 1,000 research groups to perform this challenge. I thought I'd also mention briefly why I've been involved with the Mikai conference over many years. This is a very high quality conference. I found that at the Mikai conference, they generate ideas about how to solve hard problems. And they explore a wide variety of applications and solutions. So, for example, it's not just radiology applications of AI that are described there, but also applications on other biomedical imaging, including digital pathology, ophthalmology, and so forth. And sometimes these solutions can be translated to radiology problems to help solve them. So one doesn't need to reinvent the wheel. Sometimes also new important techniques appear. A number of years ago, the UNet algorithm was first presented at the Mikai meeting, and now it's ubiquitous for image segmentation. Another very personal reason why I like Mikai is that because not many clinicians attend, I have a valuable role in providing clinical context, which I think is valued by the other participants and provides me with a sense of personal satisfaction. Just a few more words about the importance of large data sets. As has been described by my two colleagues in this webinar, AI thirsts for data to learn a range of variability in our patient population, not just normal versus abnormal, but we can see variability according to patient age, gender, and race, variability due to acquisition technique, including whether or not contrast material is used, the radiation dose to the patient, and the reconstruction algorithm. Also, images from different vendors can lead to different performance. And the quality of the labels, as we've just heard in Dr. Maier-Hein's presentation, can be very important. And in my own work, I learned back in the early 2000s the importance of a large data set for virtual colonoscopy computer-aided polyp detection. This is a 1 centimeter polyp in the colon on a CT colonography scan. And in that study, we needed 1,200 studies from the Department of Defense, a CT colonography screening trial in order to do this research. A few words about why one might want to create one's own data set. Why would you want to do this? It's a lot of work to create your own data set. Well, some good reasons to do that are that public data sets may not address your research problem. You might have specialized knowledge or skill about a particular clinical problem, and the public data sets are not suitable for your particular project. A real downside that I see to public data sets is that it encourages repetitive so-called Me Too low impact research. And I recently looked into this for an editorial I wrote in Radiology, the journal Radiology, about COVID-19 on CT, where I found hundreds of papers published using the same data sets, all doing the same thing on segmenting COVID-19 on CT scans, and really leading to less than useful repetitive research. I mentioned earlier that one of the things that excites me is the use of large-scale data sets to promote scientific discovery and the advancement of knowledge. And this is an example from a collaboration with Perry Pickard at the University of Wisconsin-Madison that we published last year in Lancet Digital Health, where we applied 5 different AI algorithms developed by my group, including visceral fat, muscle density, volumetric liver density, abdominal aortic atherosclerotic plaque calcification, and L1 vertebral body bone mineral densitometry into an algorithm that was shown to predict mortality and cardiovascular morbidity like stroke and myocardial infarction more accurately than the more commonly used BMI and Framingham risk scores. So if one creates one's own data set for one's own research, should one make it public? I think there are so many great arguments for making your data set public. It permits reproducible research, permits others to improve algorithms. It encourages interest in medical imaging AI, and it provides recognition to data set authors. And I and others, including Michael Veneer, in this editorial we wrote quite a while ago in Radiology, have tried to promote the idea of sharing images. And we have done that in my group. We've shared 4 of our data sets publicly, including the NIH chest X-ray 8 data set that I've already mentioned, but also the deep lesion data set of lesions on CT scans, the Cancer Imaging Archive pancreas CT data set for pancreas segmentation, and the Cancer Imaging Archive lymph node CT data set for developing AI systems for an important application in oncology. Now, all of us in this webinar have talked about using large data sets, but generating the labels for these large data sets is very challenging. We don't always have the 18 radiologists that got together for the RSNA pneumonia detection challenge, and sometimes one has to use less labels. And in my lab, we've been looking into some alternatives to manually annotating tens or hundreds of thousands of cases. And these include such things as zero-shot and few-shot learning, transfer and unsupervised learning, semi-supervised learning, and federated learning. We heard about federated learning in Dr. Linguraru's presentation. The images on the right show work from Angshuman Paul, a postdoctoral fellow in my group who has been a leader in developing systems using few-shot and zero-shot learning. In proof of principle studies using chest radiographs, Angshuman showed how it was possible to do zero-shot and few-shot learning in radiology. And if you're interested in that topic, I encourage you to take a look at his recent papers that just came out in Medical Image Analysis and IEEE Transactions on Medical Imaging. So to conclude, in my experience, engaging with data scientists is fun and fruitful. I love working with data scientists, and the contributions that they make have been just fantastic and cannot be underestimated. I think that radiologists and data scientists each make key contributions to successful AI projects, and working together, we can really advance the field and hopefully produce AI systems that lead to clinically actionable and impactful systems. I'd like to acknowledge the individuals who contributed to the data that I showed in this presentation, the many funding sites, and welcome you to take a look at my website and our GitHub site where you can find some of our code. Thanks very much, and I look forward to the panel discussion.
Great. Thank you so much, Ron. It was a great talk. So I'd like to invite all of our panelists to come back online. There we go. And to members of the audience, just to remind everyone that we are recording the session. It'll be available on the RSNA YouTube channel within a couple days. And we invite you to submit your questions to the panel through the Q&A tab on screen. So I hope you'll do so. We have a few questions that have come in. And if you see a question that someone has already asked that you think is a good one, please give it the thumbs up and we will upvote it. I'd like to give the first question to Marius Linguraru. Marius, are AI algorithms, is there an expectation that they will outperform radiologists? Is that part of what the thinking with many of these?
Well, I think this is a complex question, right, that is in everyone's mind, and the answer to it is not simple, because I could easily say both yes and no. And the difference in that may be in the context of the question. And what is the AI algorithm supposed to do? Is it a decision support? Is it a screening? Is it making the decision? Then is the mistake just human, or is it shared with the machine, right? Particularly when making a clinical decision, and do we hold machines at higher standards or not than we do for clinicians? And since I was mentioning some different scenarios, for instance, in screening, I think if you use an AI system that could pre-select which images to be reviewed by a radiologist, it should have very high sensitivity, but not necessarily very high performance overall, because there will be a radiologist who will read the data. And it will still add great value by reducing the workload of the radiologist. But if an AI system will complete the examination, then it should be held at a higher standard. And that means at least at the same level of performance as a radiologist. And one thing that, scientists like myself are often asking, like, if we do training and validation of the algorithms by learning from radiologists, will they be able to outperform the radiologist? And in situations like that, sometimes I think that even if we want to have a very good radiologic AI system, may have to be trained on other type of outcomes. I can give a brief example, because some work that we have presented at RSNA in the past, where we're looking at pediatric hydronephrosis, which is reviewed in ultrasound, of renal ultrasound, very easy to detect, not so easy to predict kidney function from it. So because radiologists use most commonly the ranking of the Society of Fetal Urology to rank them from mild to severe. And what has been shown that this does not correlate with kidney function. So what have we done then? We're looking at the outcome of those kidneys. We're looking at the drainage. We're looking at the presence of urethropelvic junction obstruction. We're looking at kidney function, and we train the AI algorithm with this kind of outcome, but then we apply it in a radiological way, and that outperforms the visual interpretation, right, the radiological interpretation. I can also, I would like to make maybe a little parable to go back to how AI outperforms humans. And there was a paper a couple of years ago, I think in the Journal of Artificial Intelligence Research, in which researchers in machine learning participated in a survey to predict how AI will outperform humans in activities in the next 10 years, 50 years, 100 years. Everybody agreed that some basic tasks that are basically pattern recognition, like writing, translating, driving, will be outperformed by machines in the next few years. But the questions that were related to healthcare, there was nothing related to radiology, but there was a question like, will AI work like a surgeon? Then the prediction was much later in time. And not only that, researchers in Asia were a lot more optimistic about how long it will take to get there than researchers in North America. So I think when we want to think about what's the performance of the AI system versus the clinician, we have to think about also social, psychological reasons behind that, legal reasons as well. So that those have to be taken into context. That, do I think that AI will become omnipresent in healthcare? I absolutely do, and I think in radiology included. And I think I'm hearing from my colleagues as well, comments on the same direction, that AI will not replace human workers. It will not do it now for sure, but rather assist them. And the best performance, at least in my opinion, will be that of radiologists working routinely with AI systems and learning to do that, particularly also as AI systems are also getting smarter and will learn to work better with radiologists. So the meeting will be somewhere in the middle.
Great, thank you. Lena, this is a question from the audience. Ranking algorithms in competitions is important, but many algorithms are developed using independent data sets. And comparing algorithms in the literature is quite difficult with sparse reporting of different metrics. What steps would you suggest for researchers publishing algorithms that are doing so outside of not using competition data sets?
Yeah, good question. And we're looking into this as part of the MONAI initiative, actually. If you have further thoughts on it, please contact me. So I think the ranking, the metric part is quite straightforward. So we're working on it. And I think we should use standardized metrics to some extent. But what's really tricky, I think, is the benchmarking part, because if you re-implement an algorithm, it has been shown that you put much less effort into it and you bias basically the comparison. So that's not a good solution. So one thing, of course, is open source on the side also of the journals, to encourage authors to release their source code, or at least, Dockers, the models, resulting from the algorithms. This would really give a boost, I think. Alternatively, of course, we can go towards standardized data sets. And I really appreciate, for example, Nature having released the Scientific Data Journal, which gives incentives, for example, for releasing data open source. And then, lastly, something that could be done is, if you, for regulatory reasons, you cannot release the data, we could start thinking about infrastructures, for example, Rsna actually, to do something like an external validation where you keep your data, but people upload basically their algorithms, and you basically provide the results, certify the results, and then this becomes comparable to what other researchers do. But I think there's a lot of things to do from an infrastructure perspective, political perspective, journal perspective. Yeah, if you have ideas, we're trying to push this further.
Great, thanks. Thank you, Lena. Ron, a question for you. How do you build your own data set so that it allows for robust investigations? Any tips or suggestions you can offer?
Right. So ideally, one wants to have a consecutive series of patients. That's one way to reduce selection bias. Ideally, one also wants to have data from a variety of scanners, a variety of institutions, but it can be quite tricky. Another thing that's important is to have adequate diagnosis material like histopathology. In some cases, you need biopsy for prostate cancer data sets or for liver fibrosis. So there are a number of important factors involved in putting a proper data set together. And then once you have a proper data set, one has to think about how one's going to divide it up into training, test, validation, and testing sets, and then ideally perform external validation so that you can show the generalizability of the algorithm. So there are a number of factors that go into it. There have been some nice papers about this that go into the details of the data set. For example, the claim criteria in your journal, Radiology, Artificial Intelligence, provides a nice checklist of some of the things that go into producing a high quality data set. And I think effort put into putting together a high quality data set and high quality reference standard are well paid off in terms of the impact of the manuscript and the research.
Great, thank you. I guess, and I'll put this to all of you, and maybe Marius, if you want to start, but what do you see as major barriers or challenges to sharing of large data sets that could be used in competitions or for validation of algorithms?
I can take a brief answer to that. Well, I see a couple of things happening there. First, ownership of data. And I think there's often barrier there, right? Well, people are holding to their own data. And that comes with maybe other challenges behind it. There is a lot of paperwork that needs to be done. There is a lot of patient protection that needs to be put into place. You have to get a lot of boxes ticked to get the permission to put data into the public domain. And then I think there is also, people are held back sometimes because there is a quality control also that needs to be put into these data sets that may vary, again, from individual to individual, institution to institution, and data that are put in the public typically have to meet high standards, or they will be also often open to criticism.
Great, thanks. Lena, how do you envision the next generation of radiology AI challenges? It's something I know you've given a lot of thought to as you've helped coordinate and choose these for the Mikai challenges.
Yeah, so I think a current problem is that basically the way validation works, when you do your independent research, but also in challenges, typically all the data that you have is taken and then you split it into training and test data. And from a mathematical perspective, this means that the distributions of your training and test data are similar or identical, whereas in practice, you have what we call a domain shift. You have different scanners or different protocols or different positions in which the patient images were taken, etc. So I guess what I would like to see is when we perform a challenge, I would like to see the winning algorithms undergoing a real life prospective crash test where data is taken from other sites, for example, under other conditions, and see how they really perform in real life. I mean, because for me this would be much more convincing than taking training and test data from identical sites and under identical conditions.
Great, thank you. And Ron, a question that's come in: any resources that you would recommend to radiology residents who are interested in learning more about machine learning, radiomics, and AI to get an understanding of basic concepts and how this will figure into their practice in the future?
Yeah, thanks for that question. One of the other attendees put into the chat about the Magician's Corner that is a series published in Dr. Kahn's Journal of Radiology Artificial Intelligence, and that's a great series to learn about the basics. Another great source is there are courses at Coursera and other online platforms that can teach you about convolutional neural networks and other techniques used by AI researchers. These sometimes are free, other times one needs to pay, but there are many online resources. Another thing that people can do is take in-person training. For example, my lab offers training for undergraduate students. We also have postdoctoral fellowships. So, we have summer internships. So there's a variety of training opportunities at NIH as well as at other places around the world, probably including my co-panelists. So many, many opportunities, both online and for in-person training.
Great, thank you. Marius, a question to you. I know one of the things that you've been concerned about is the notion of trust and sort of the black box functionality of AI models, as we sometimes talk about. How can we make AI explainable to radiologists? How can we make it to improve trust and also just so that when we use these tools that we have a better sense of what it is that they're delivering to us?
Yes, thank you, Chuck. And I saw there were several comments on the Q&A about this, because indeed trust is very important, and in many things, right? And particularly in healthcare. So maybe what I focus more is how can we learn to trust certain things that are hard to explain? Because I think if the box is not black and comes out with explainable features, then it's easy. We understand what it wants. But when there is a disconnect between the AI system and how the human thinks, right, the radiologist thinks, then that becomes more challenging. And opinions are very mixed about this and whether this represents a big problem in healthcare. Because the black box may predictably and constantly improve patient health. So then should we just keep using the box, even if we're not exactly sure what is happening underneath? But there has to be some level of trust to be able to work together, and that requires some kind of transparency. So I'll get back to the fact, I guess, what I want to insist on is that if the box meets human logic and intuition, that may be sufficient. We're not exactly sure how the processing is done inside, but we think the same way. But if the box does not, how do we come together? Will it predict something that is useful clinically? A clinician may not see that information, but the box predicts something that is useful. It may be harder to accept, but again, it's done consistently and correctly. We may learn to accept it. And for that, what I think the key is to have some kind of scientific premise. And watching the news, I think we've just seen AstraZeneca releasing, right, the latest evaluation of or the vaccine. I mean, those vaccines may not be, and the trials for the vaccines may not be black boxes, but I think for probably a wide population, they do look like black boxes. And we don't know what are going to be even the long-term effects of these boxes. But polls still show that there is a preference to use a vaccine with proven protection. And I think that's a conscious decision of the same type of using a black box and trusting a black box. And this is something, right, that happens every day. Lena spoke also about, right, the pitfalls of what I said, the black box. Are these boxes well trained? Are the data diverse, adequately tested? Are they confounding factors? Ron was also mentioning this. So the black box can become really good, but it's very finicky until it gets there. But again, it's not magic. And I think we have to understand from both sides, the radiologist's angle and the data scientist's angle, what is happening with the box, what the box needs to provide, how to validate it well. And I think at that point, we can trust the box.
That's great. I'm going to take moderator's privilege here and answer one of the questions that came in, which was, how can an interested radiologist learn to work with machine learning experts? Is there a public forum? Where can we get connected to do collaboration? So I guess, first off, I just want to say there are lots of resources through the RSNA. There's an AI community that has a discussion board that you can participate in and learn through. There are courses such as this one and the various things through the meeting. The Radiology AI Journal offers a number of things, and mentioned that Magician's Corner that was created by Brad Erickson, and it's based on the quote from Arthur C. Clarke that any sufficiently advanced technology is indistinguishable from magic. The idea being that if we think of this as just technology that we don't understand, then it really is magic to us, but we can learn to tame it and master it. And actually the Magician's Corner articles in the journal will give you a hands-on experience in actually using some of these technologies. But other than that, also, I'd say consider joining Mikai, consider learning from connecting with various experts, and it's quite likely that in your radiology department, if you're in an academic center, there are researchers there who are, if not themselves doing work in AI, they are connected with people who are doing work. And I'm sure my panelists here will join with me and saying that if you wish to email us, we'll help try to connect you with people. So, pardon me. Let's see who else, what other questions we have here. One of the main issues with clinical implementation of AI systems today is this issue of transferability. And other than using a very large comprehensive data set that comes from various sites, leveraging federated learning, has been important. Are there any other strategies to make sure that algorithms don't suffer significantly when transferred from one setting to another? And I guess, Lena, I'll pose that to you.
Okay. Yeah, yes, there are. It's actually an exciting research topic also in the general machine learning community. So one strategy is, well, basically the network can take the input, the image, for example, and the network transfers this information into a new representation. You can think of it as a vector. We call this latent space. And you can train the networks in a way that basically they encode information that is relevant for what you want to do, for example, differentiate a disease, from the information that is, for example, encodes the information on which hardware you used. So we call this disentanglement. So we basically transfer the data to a different space in which we disentangle the different factors. I mean, it's work in progress, but it's one of the things that you can do. I mean, there's also many other methods, but just to give you an idea. So you can certainly also address the issue from a methods perspective, not only from a data perspective.
Great, thanks. And Ron, to you, what do you see as the major barriers or challenges to sharing large data sets such as you've done?
Well, it's very time consuming to do it. First, you have to get the various approvals, of course, IRB approval and other privacy related approvals. And then one needs to develop the annotations and then check the images for any residual protected health information, which can be pretty time consuming. When we put together the NIH chest X-ray 8 data set, there wasn't a lot of knowledge about how to prepare large data sets for public release. And so some of the things we did, we had to learn on our own. For example, we ran optical character recognition on the images to find any residual text, and there was really no good reason to have text burned into the image, but it turned out that in a small percentage of the cases, there was text burned into the images, things like dates and numbers relating to, for example, the cassette for computed radiography. So, I've heard from other researchers who are putting together public data sets that they're still running into issues with burned in text. I imagine that's because they're going back to older data that may still have text burned into the images. And at the time we put that data set together, we didn't have a place to put the data. And that turned out to be a challenge. Nowadays, it's easier and easier. Some of the data sets that are being released are quite large, like the Rsna CT pulmonary angiography data set is exceptionally large. But there is a cost to making very large data sets publicly available. Our smaller data sets are on the Cancer Imaging Archive, and our larger data sets are on a box site that is paid for by my institute, the clinical center where I work.
And I know there are some special considerations too that relate to assuring privacy of the images. I mean, even today, I mean, ultrasound images will often have patient identifiers, burned in, right? But even on a chest radiograph, if someone has an implanted pacemaker, it may have a serial number that is visible on a radiograph. And I think many people are also aware of the concerns with head CTs or MRs where you could extract facial profiles. And there's a lot of people talk about defacing CTs, right, to preserve privacy. That's an important consideration.
We did run into that. We ran into that problem with the deep lesion data set. Some of the CTs included the head, so we just removed all the pixels and starting around the orbits, just chopped it off, replaced it with black.
Okay.
So, yeah.
So, Marius, a follow-up question to you about AI systems reaching human level or superhuman performance. How does the panel suggest to prove human performance in the quality of a model that might be benchmarking against a human ground truth, in the sense that we're all, we're our own gold standard, I guess, in many ways?
I think that that's really a question that needs to be answered for every application in itself, because right, the details are going to be critical for answering this. But as I was, I think, indicating earlier, sometimes we have to change the benchmark, and that benchmark may be an outcome. And for looking at that outcome, we can also put a lot more diverse data. I mean, one of the beautiful things about AI, I'm starting to sound like I'm the champion of AI, and I just want to be very clear that I think AI has a lot of pitfalls. I agree with my colleagues very much on that. But one of the great advantages of using AI is that you can add a lot of data and a lot of diverse data. So you can look at interpretation of more complex data against what is maybe done as a standard routine clinical care. But also, I think that AI systems need to be trained against an outcome that may not be the answer of an image, may not be the answer of a blood test, but something, with a longer term, with a bigger impact. And at that point, I think the system itself may start to look at data differently, may start to analyze, may start to change, maybe in a way, the routine clinical care and management for a certain group of patients to find the shortest cut to reach that outcome. So I think that's where we can hope and we can aim, or that's one of the strategies where we can aim to have systems that outperform the human reader. But also we have to aim for systems that are simpler, that don't have to outperform the radiologist or another clinician, but that can support, can simplify, can increase the value of the interpretation of the data again in routine clinical care.
Thank you. And Lena, a question to you. Any thoughts, and the question says politics. I think they mean government-sponsored grants and so forth, about how sponsors can incentivize research that is useful on a large scale, including global collaboration. Do you have thoughts about that, or do you see how either government sponsorship or other organizations may foster AI research on a, that would allow us to get to kind of a bigger picture in many ways?
I mean, I think we don't have a problem with lack of AI sponsoring, because I think this is sponsored quite a lot, but I think we have, I mean, we need, I guess, more funding for, data sharing and all these things. But I think politicians have become aware of it. So I see more and more calls in this direction, or grants. For example, if you get a grant, you may need to publish your data afterwards. So I think this is a pretty good mechanism. Then, yeah, also I already mentioned some journals that incentivize data sharing. So for me, it's all about the data. If we manage to put all the data and all the resources together to annotate the data, we would be so much further now compared to just everybody having their own little data set. And I do think incentives are key for moving forward. So yeah, coupling funding and sharing data is an example.
I'd like to second that.
I think a lot of us who are attending this want to learn more about it. I just wanted to, have you had difficulty engaging other radiologists to work in AI? What's your experience been of finding people to collaborate and to engage them and their interest in this field?
Is that for
Is this
me?
a question?
I'm sorry, that was to Ron.
To Ron.
I wanted to just briefly follow up on what Lena just said. I definitely agree. If there were more data sets publicly available, the field would have moved much faster than it has, and we would probably see it would be much sooner for clinical applicability. I envision 10 years from now, with the continuing growth in the number of data sets, that will be in a scenario where more and more of these data sets can be aggregated to do holistic or total scan image analysis. And I think not having the data sets is holding the field back. Your question, Chuck, was about finding other radiologists to engage other radiologists in working on AI. I think there are always some radiologists who are enthusiastic about new technologies, particularly AI. And in my experience, I've just had to look for those that show an interest. I have found that there's quite a bit of interest out there, and that radiologists may not be fully aware of what's possible. So for example, I went to a session led by one of the NIH institutes about body composition analysis, and a number of presentations were given. And if one of the presenters was kind enough to show some of my lab's work, and we started hearing from people who had no idea that AI to do body composition was possible. They thought you had to do it manually. And there are many attendees on that webinar, and when they learned about the availability of these automated algorithms, they started contacting me and offering to collaborate. So there seems to be a communication issue, and I think we have to find ways to reach diverse audiences, not just to reach radiologists, but clinicians and other clinical researchers, because when they learn about what we're able to do, they can get really enthusiastic and want to collaborate. They just don't know, they just don't understand the capability. They may be turned off by the terminology, artificial intelligence or whatever, but when it's made concrete, about, we can make the measurements that you've been doing manually. We can do it fully automatically on hundreds, thousands, tens of thousands of cases. We can enable you to do population-based studies that epidemiologists want to do and may not realize is possible using images. So lots of opportunities for engagement.
Well, and I just want to add to that too, that I think the history of the RSNA challenges, the AI challenges, has really shown a lot of enthusiasm among radiologists to contribute in this area. As you mentioned the 18 expert chest radiologists who contributed to that pneumonia detection challenge. They took the publicly accessible data set and they drew bounding boxes. They actually demarcated on the radiographs the areas where pneumonia was present. And we had some 60 neuroradiologists who participated in the brain hemorrhage detection challenge by annotating. It ended up being more than 1 million head CT images total. I mean, it's a tremendous amount of effort, but it creates these, as you said, expertly annotated, high value data sets that can be tremendously useful for further research. So I think
it's really hard to get such expert annotated data sets. If a single institution does the annotation, they might be able to have a few radiologists verify the annotations. But when you have professional societies or large numbers of radiologists doing the annotations, it's the kind of annotation that you tend to get only from the bigger, well-funded studies, the NLSTs, the DMIST studies, those sort of really well-annotated data sets. It's costly to do that, and to have so many radiologists volunteering their time to do these annotations is a real contribution to the community.
So I'll send this question to Lena, but I guess others could join in. Are there network models that include more information in the input other than the image that incorporate non-imaging information?
Yep, certainly, yes. I mean, it's all started more or less with the traditional models that work on grid structures like images. But now we have all sorts of models. I mean, one example are graph neural networks where we actually work on graphs, no more grid structure at all. They get quite a lot of attention, but you can also combine traditional models with other inputs. So short answer, yes.
And I know there was some recent research showing, for example, that combining mammographic information, the image information, with the usual clinical risk factors, for example, improved the prediction of risk in breast cancer, for example. So yes, I think that's a great question.
I would add to that, Chuck, that it's actually quite a new norm in medical imaging. We are often moving away from using just the image data because we know what are the limitations. Sure, from a research point of view, if you're looking for some imaging factors that are good predictive models, then you would use the image for that. But often we're using this in combination. And I think that the example I showed earlier as well, using federated learning, that was combining a variety of other results that were available from the EMR, from the demographic, from all kind of lab tests that you get from a patient, which will contribute to the value that can be extracted from the image to make a faster and more accurate prediction.
Great. So here's a question. I'll just toss it out to the group. And how will advances in AI influence next generation CT scanners? Any thoughts?
I thought about it the other day, but I think in the traditional, say, product cycle, you would get a lot of feedback from people who use devices, explicit subjective feedback. And I think one thing that AI could do is actually just monitor how people handle a device, which protocols they use, and all these interaction things, and then automatically improve basically future product design, or also have something like custom designed settings, you know, like preferences. You see this all the time in, I don't know, social media, personalized ads and all these things. I think you could transfer it to such a setting as well.
And I think in CT also, there is a lot of work being done for basically improving the quality of the image with, you know, less radiation, more focused acquisition. But I think radiation is a big question, right? With CT. In other types of imaging, you're talking about time, you're talking about comfort. So what AI algorithms can help in the construction or reconstruction, that depends how you use the algorithm of these images. And I can see also where they could guide the machine better, they can guide the parameters of the machine, they can focus better on the anatomical part that needs to be acquired, basically helping the technologist and doing some of the work the technologist is doing now, where we know imaging is very personal, right? We have to play with the machine for every patient, so AI can simplify or make that faster.
And I'm curious about the role of raw data, actually, because maybe now there's things that we don't see on an image, on a reconstructed image, but knowing, for example, that a lesion developed and reprojecting this knowledge back on the raw data taken at an earlier point in time might help us for early detection, for example. So I think raw data will play more of a role.
I will just add, I know, you know, for me, it's fascinating that for CT, you know, with the back projection retinal transform, that is an analytic method, right, for producing the image from the raw data. In fact, we can create deep learning tools that will do that function, you know, and so some have even asked the question, why, you know, if the only reason we're reconstructing the images is for the human eye, perhaps the machine can do as well or better just from the raw data if it can understand that, and you know, in some cases has been trained to recognize abnormalities, and same with MR as well, right? To do faster sequences, you know, more limited case space sampling, and be able to generate that. It's an interesting question.
Yeah, and I think Lena hinted to that a little earlier also when she was speaking about, you know, common spaces that are done. Sometimes, you know, an algorithm, we're talking about data that comes from different machines, different protocols, right? The rawer it is, the easier it is in a way to interpret, not for the human eye, for the machine. And I think we as scientists, we are very excited about raw data. Yeah, we want to have data as clean as possible. But that's an interesting paradigm that you brought up as well, Chuck, because do we want to make images that are clean crystal for the radiologist or for another clinician who's looking at those images? Then there is one pathway for interpreting the data. But do you want to compute the volume of a lesion from that image? Then the machine may learn better from other type of data, that one that is useful for the human eye, and that is that, yeah, as you say, the raw data.
I will say though, just personally, having seen some of the tools that are available that improve the quality of images, right, that denoise images and do T and MR, just knowing what we can do with GANs, for example, I always ask the question: are we really seeing that? You know, did the computer just make the liver look smoother and better for my benefit, or is it really helping me detect lesions better? And I think that's, you know, one of the questions we have yet to fully understand. But there's, I think metal. Yeah, right. They improved
metal artifact,
some of the metal, the streak artifact. Yeah, tremendous opportunity. Well, even the notion that if you're going to build an AI algorithm that, say, detects a malpositioned endotracheal tube on a chest X-ray, why not build that into the digital radiographic unit itself? So before the image is even transmitted to the PACS, that the technologist sees the image on the screen, a little alert comes up, and someone can, you know, find the physician who's caring for that patient and say, this patient looks, you know, may have a malpositioned endotracheal tube, right? You know, so we can actually accelerate the processes of care in many ways. I think we're actually approaching the end of our 90 minutes here. I just want to say it's been absolutely extraordinary having the three of you as panelists today. I'm very grateful and appreciative for your time and for all the thoughts. I'd like to thank you all for sharing your expertise and time, and to everyone online, thank you for attending today's webinar. Just a reminder again, it'll be on the RSNA YouTube channel within several days, along with a variety of other resources. And with that, just remains for me to say thank you again, and take care.
Thank you.
Pleasure to be here.